Welcome to This Explainer. Today, we're diving deep into a hidden crisis that's literally sweeping across the country, the fracturing of our rural healthcare system. You know, we hear a ton of anecdotes about rural hospitals struggling, but today, we're going to map out exactly what is happening to the vital medical infrastructure that millions of Americans rely on every single day.
Okay, let's dive into this. I want to pose a direct question to you. Just how vulnerable is rural healthcare in your state? If you live outside a major metro area or have family members who do, this isn't just some abstract economic theory. It's a matter of immediate access to life-saving care. So to really grasp the gravity of the situation, we've got to look at the numbers. 68%. In Alabama, an astonishing 68% of rural hospitals are currently operating on negative margins. Let that sink in. That single statistic signals a massive systemic problem. I mean, think about it. If nearly 7 out of 10 businesses in literally any other industry were losing money just by opening their doors, we'd call it a total collapse, right? But in healthcare, it's this quiet emergency. And that's exactly what we're going to explore today.
Here is our roadmap for today's explainer. First, financial margins. Second, vulnerability to closure. Third, the care deserts. And finally, the infrastructure reality.
Real quick, before we go any further, it's absolutely crucial to establish where our information is actually coming from. Everything we're exploring today is drawn straight from the 2024 State Rural Health Facts, meticulously compiled by the National Rural Health Association. This data gives us a completely objective, state-by-state snapshot of exactly where our national health infrastructure stands right now.
Let's move to Section 1 and see how this builds. Financial margins, the root of instability. So, what does a negative operating margin actually mean? It simply means a hospital's operating expenses exceeds its operating revenues. In plain English, they are losing money on the actual care they provide. We aren't talking about failing to turn some massive corporate profit here. This points to foundational financial instability. A hospital just can't survive indefinitely when the fundamental math of keeping the lights on looks like this.
So how bad is it really? Well, let's start with what we might call our best-case scenario baseline. Over in Alaska, only 15% of rural hospitals operate on negative margins. Now sure, ideally you'd want that number to be zero, but in our current national landscape, 15% is actually relatively stable. It proves that maintaining a viable rural health system is possible under specific conditions.
Now, what's really interesting about this is the staggering contrast when we look elsewhere. We jump from Alaska's 15% all the way over to Connecticut, where an unbelievable 100% of rural hospitals are operating on negative margins. Literally every single one. This stark contrast shows us that financial distress in rural healthcare isn't just some localized fluke, you know? In some regions, the economic model for rural hospitals is completely broken.
Section 2. Vulnerability to closure.
You see, a negative margin isn't just an accounting headache, it's a countdown clock. We are moving from financial theory to an immediate physical threat. When a facility finally exhausts its financial reserves and lines of credit, it simply shuts down. The data lets us calculate the real-world risk that these hospitals will have to close their doors for good, leaving their surrounding communities completely stranded.
Just look at the extreme variance in closure vulnerability across the country. Up at the top, we've got Arizona, where a staggering 50% of all rural hospitals are vulnerable to closure. Half of them. Florida and Georgia aren't far behind at 43% and 34%. But then, as you move down the list, you see this steep drop-off. California sits at 10%, Arkansas at 6%, all the way down to Alaska again, where exactly 0% of rural hospitals are considered vulnerable to closure. It's a completely fragmented national reality, where your zip code heavily dictates the stability of your local ER.
Section 3. The care deserts.
As hospitals face closure and resources shrink, we've got to look at the immediate impact on patients. The government tracks these impacts through what they call health professional shortage areas, or HPSAs. And this brilliantly illustrates what that looks like in Georgia. It translates into an absolute care desert. 85 out of 85 rural counties are classified as mental health shortage areas. That is a completely full chart. The visual impact here is undeniable. If you live in a rural county in Georgia and need mental health care, you are living in a literal care desert with a 100% shortage rate.
But unfortunately, this isn't just an isolated incident. Look at how systemic this issue is across vastly different states. In Alaska, 26 out of 26 rural counties are mental health shortage areas.
In Arizona, every single one of its 7 rural counties is a primary care shortage area. Connecticut's 1 rural county? It's a shortage area across all tracked categories. And in Florida, all 22 rural counties lack adequate mental health professionals. We're seeing massive, sweeping shortages across entirely different geographic landscapes.
Section 4. The infrastructure reality.
So if traditional hospitals fail, what remains is a patchwork of physical infrastructure. Traditionally, rural areas relied heavily on critical access hospitals. These are the small facilities that provide traditional 24/7 emergency and inpatient care. But as those struggle, states are increasingly leaning on alternatives like federally qualified health centers and rural health clinics. These health centers focus on vital outpatient and preventative care, trying desperately to fill the massive gaps left by struggling traditional hospitals. Notice how states rely on wildly different combinations of facilities here. California maintains 38 critical access hospitals, but heavily leans on an expansive network of 328 federally qualified health centers and 277 rural health clinics to cover its population. Illinois has a more balanced approach, with 55 hospitals and 115 health centers. Meanwhile, Arkansas relies on a strong mix of 158 health centers and 145 clinics against its 27 remaining rural hospitals. This is the new, patched-together reality of rural medicine. Sometimes, to avoid shutting down entirely, a facility will go through what's called a conversion. Basically, this means they transition from a traditional inpatient hospital into a different type of facility, like a standalone emergency center or a clinic, which often means stripping away overnight inpatient beds. Since 2010, states like Alabama and Georgia have seen 6 of these hospital conversions each. California and Florida have seen 5. It's a survival tactic just to keep the doors open, but it fundamentally changes the type of care available to the community. So the crucial point is this. The vulnerabilities we discussed earlier aren't just future predictions. They are grounded in an ongoing historical trend. Looking at hospital closures since 2010, we see the very real physical loss of infrastructure. California has completely lost 4 rural hospitals. Florida and Georgia have lost 3 each. Arizona and Arkansas have lost 2, and Alabama 1. These numbers represent locked doors, lost jobs, and most importantly, patients who now have to travel much, much further during a medical emergency.
We've seen the data today. We've tracked the negative margins, the severe professional shortages, and the steady drumbeat of closures across the nation. And it leaves us with a critical, urgent question. With financial margins plunging and care deserts rapidly expanding, is your local rural hospital next? Thank you so much for joining me for this explainer. Understanding the structured data is the very first step toward addressing the crisis. Keep learning, keep asking questions, and I'll catch you next time.